I think when we did the initial test, what we didn't take into consideration was that there was an iCloud recording taking place, and the Mac flagged it up in the security settings and blocked it. So that was the reason why it wasn't working.
The drawbacks of having a fancy computer.
Okay, so this was, as I'd mentioned, 1995, lung RFA in rabbits. So this was published. 5 years later, we have the case series in humans, and this was 3 patients in the AJR. And this, following on from that, this is my own personal research, which I did during my fellowship, and we looked at colorectal lung metastases and survival following radiofrequency ablation, and this was published in CVIR. What I'm going to do today is I'm going to go through a series of cases, simple, complex, difficult ones, problems, where not to ablate, what can go wrong, how to deal with it. So from thermal ablation of lung lesions, from the simple to the complex. So we start off with something relatively simple, radiofrequency ablation of this patient, 35-year-old lady. And she had a surgical treatment and followed by chemoradiotherapy. And she's relatively young, only 35. And what happened is that she developed a solitary lung nodule, and this was confirmed to be metastatic on FNAC. So what we did in this case was radiofrequency ablation, and you can see the probe positioned in the distal aspect of the lesion, which is what I like to do. I like to do overlapping ablation cycles in different areas of the lesion. And here you can see the lesion positioned a little bit more centrally. And this is just showing the tines where the black arrows are, that we've completely encompassed the lesion. And this is a Levine electrode, so most of 3/4 of the burning is under the umbrella. And this is showing the ground glass density opacification after the ablation. And the same thing is seen in the sagittal. This is the following day, and this is the follow-up at 3 months. And this is sort of this is what you want to see, a sort of a gradually shrinking ablation zone. And then you can see the follow-up at 6 months, where all you're left with essentially is a rather thickened parenchymal band representing residual fibrotic tissue. And then again at 9 months, at 1 year, and she was followed up for several years. And so she just had the 1 nodule, excellent result, and disease-free. So that's sort of relatively simple. It was 1 lesion, it was nicely surrounded by lung, no vital structures, no mediastinal structures, no pleural structures, and no complications. And so just to highlight, so the ideal lesion is a solitary or maybe 2-3 lesions, 1.5 to 2, but again, if you're treating a solitary primary lung cancer, even up to 3, preferably no medical issues. That way you can do it under sedation, but you have to be careful. Any lesion which is near the diaphragm probably needs a general anesthetic. And then the last point is that at follow-up, if the patient brings some biscuits or something else perhaps. So that is the ideal patient. Okay, so now I'm going to go through some patients with such a left. A 68-year-old gentleman, rectal adenocarcinoma, radiofrequency ablation of his lung metastases. And this patient has already had a left some of the hilar or the segmental bronchi and artery. With these, reason is that you just cannot get I haven't the print that I'm using on this occasion, and you can, and it's a sort of a traumatic pneumothorax, and I just cannot penetrate the lesion. So what I have to do is I have to do, or you're going to get a very large
Zahid, there's a little bit of, we can't hear you that clearly. I don't know, are you using a microphone or something, or just the sound seems to come and go?
No, I'm just using the. Okay, I'll speak a bit slower, maybe. Surgical emphysema and a small pneumothorax. This is 4 weeks later, and a lot of us now closed. This patient had 2 other lesions, and on this occasion I chose the RFA with the cool tip electrode. And you can see the lesion close to the pericardium, and we have to be a little bit careful over here because we've got the phrenic nerves. So especially the over here, now you will not be able to easily identify these nerves, and they can vary a little bit along their course. So be very careful, because we don't want a phrenic nerve palsy. These are the same patient, large ablation zones. Unfortunately, there was no follow-up. The interesting thing was that he was a retired surgeon who trusted the interventional radiologist. I'll move on to another patient, a 57-year-old male patient. He had, again, invasive adenocarcinoma of the rectum. He's had surgery, he's had chemotherapy, he's had everything that can be done. And he was referred initially with an 8mm lesion, but by the time I saw him, it was 12mm in size. I also noticed he had a second lesion. And again, FNAC was done to confirm the diagnosis. And this is the increase in size since the initial referral. And this is the Levine. So I've used the soloist needle, and you can see that there's a small amount of hemorrhage. And at the time, I thought I had a good result, and I had encompassed the entire lesion. And you can see the lesion there, and this ground glass density opacification. Normally, we're aiming for at least a 5mm margin in the case of metastatic nodules. But although the ablation zone initially shrunk, so it went, and you can see it looked like I had a very good result on the follow-up CT a few months later. But in actual fact, on further subsequent follow-ups, we can see that it's now beginning to increase in size. And I think retrospectively, what I was taking to be the ground glass density opacification may have involved an element of hemorrhage. And probably I didn't get complete tumor kill, which is why 6 months later he relapsed. And we can see that although it did shrink, it then increased in size. And this is just highlighting the fact that you have to be careful of hemorrhage, and don't confuse hemorrhage with the ablation zone. All I know is that this is from his last follow-up. I know he's alive, and I know he's well because he was renewing his driving license. Okay, so we'll proceed now with a 50-year-old sigmoid cancer, liver metastases. Again, they've had surgery, they've had all the chemotherapy thrown at them. And what we have, I think there probably were 2 tiny nodules, and these are very tiny. If you look where the arrows are, maybe only 2 or 3mm in size, but this was the previous CT. But over time, they had sort of slightly increased in size. And just sort of, again, those same nodules which sort of previously measured maybe 2 or 3 meters are now sort of measuring 5 and 7. And then they've again increased in size. And one of the lesions, that tiny one there, actually disappeared. So again, radiofrequency ablation. So the important thing here is to move the tumor away from the chest wall. Otherwise, you will get a pleural burn, and the following day you will have a pleural effusion. These lesions often require overlapping ablations, and this was the final result of that nodule. And then following that, I targeted the second lesion. What I wanted to mention here is that we've now got some lung atelectasis. And if you see where the 1.2 centimeter lesion is, and you look at the images on the right, it's difficult to be sure where exactly is that lesion. And that's a problem. And I'll tell you why that's a big problem. So she was an obese patient, and I think when I flipped her prone, that's where we ran into trouble. Again, just highlighting that where the arrow is where the lesion is. And that's important because we've got the sympathetic chain running all along the length of the neck of those ribs. We've got the two sympathetic chains. So that area of atelectasis and the lesion were in the region of where the sympathetic chain was. So I decided not to ablate, and I waited. And then after 2 weeks, that all cleared away nicely, and I was able to proceed with my ablation. Again, I introduced a small pneumothorax just to protect the pleura before burning the lesion. And you can see the probe position within the lesion and the small iatrogenic pneumothorax just to protect the pleura. And that's the final result, and that's a nice ablation zone. This is another very interesting case. So this is a primary lung adenocarcinoma. So it's a 71-year-old lady, and she has got lots and lots and lots of medical problems. I just, as you can see, so I won't go through the entire list. FNAC confirmed adenocarcinoma. And we can see the lesion, and we can also see some other structures there. So we can see this large pulmonary vein. We can also see two of the subsegmental bronchi going into the lesion. So these are sort of relative contraindications. Pulmonary arteries can be embolized prior to treatment, especially when you're dealing with primary lung carcinoma, but the veins are a bit more difficult to treat. Now here we want at least 1 centimeter for an ablation margin. If it was a squamous cell carcinoma, you could reduce the margin maybe by a couple of millimeters. And what I did multiple overlapping ablations using a super slim Levine 3.0 needle electrode. And you can see the electrode positioned in different parts of the lesions, and different ablations performed, and just some reformats to confirm position. And that's, you can see the tumor encompassed under the umbrella over here. And this is at the end of the ablation. So it's a very large ablation zone. But 3 months later, it's all shrunk. It all looks really good. But I'm suspicious of a new 6 millimeter nodule at the lung hilum, and I think it's probably a tiny nodule. But my ablation zone looks really nice, and actually it was confirmed on PET-CT. So the primary lung lesion has been adequately treated. This is at 6 months. Unfortunately, there's this focal uptake in a slightly different area. And what I like to point out that the title of the patient, HRH, Her Royal Highness, had it not been for this tiny nodule on the PET-CT, I'm sure I'd be reading the time from a Rolex wristwatch. Unfortunately, it didn't happen. A few other slightly different cases, endometrial carcinoma metastases. Again, elderly lady, she's had surgery, initially referred for a solitary lung nodule, and you can see the thickened endometrium on her sagittal CT. So this is the nodule, but I actually discovered a second nodule by the time she came to me. And this is so we've got two nodules. Now, this was interesting because when I initially, there's a subsegmental bronchus going very close to the lesion. So when I initially targeted the lesion, you can see she's quite an obese lady. And if you look at the amount of space I've had to traverse to get into the lesion, I overshot the lesion by more than 1 centimeter. And I just pulled the needle back and treated it. And I thought everything was fine. I went on to treat the second lesion, and what I do sometimes, we've now got some atelectasis, is that I will try to anchor the lesion with one of the Levine probes and then use the soloist to target it so that I can use traction and counter traction to get my needle into the lesion. And this is just showing that. However, so remember lesion subsegmental bronchus that actually bled into the small airway, and the anesthetist who was monitoring this patient with a capnograph couldn't get a reading, and he just panicked and said, stop everything, we have to resuscitate this patient. And so I had to pull my needle out, and then we found that the reason he couldn't get an end-tidal carbon dioxide was that there had been a small amount of hemorrhage which had actually gone into the end of killed. So the patient had actually only had a very small bleed, but it interfered with the filtering. And at 4:30, I'd started at 4:30, and it was 6 o'clock, and I just decided, right, I'm just not going to restart the whole procedure from scratch. So that was the final outcome. Actually, metabolic disease within a relatively short. Another cancer, he's had some good chemotherapy given to him. The reason gymnast, and he actually, in that case, we'll go ahead and we'll treat this. So this is the area of ablation. And this was it was confirmed on FNAC, and then he had ablation. Good, just showing the needle going into the lesion, and iatrogenic pneumothorax, just because I like to keep that cushion so that I'm away from the chest wall. All looks very nasty, but later on, as it sort of
Zahid, you seem to have lost audio again. It's a really engrossing talk, and it's a real shame that you're having a bit of trouble with the sound.
No, I'm sorry about that. There's a lesion again, FNA. Initial CT. Always start with the difficult lesion first. I'm not sure if you can hear me. Remember that's I'm just showing the close proximity to the pericardium. Now the issue, I just continue with my ablation while aspirating the pneumoth. This is the other lesion, which was quite small in size. So he had axe, and it doesn't project very well, but you see it there on the left side, and actually increased in size on the next. I had to aspirate approximately 800 cc. Very conscious of the fact that some of the travel on aeroplane, and he had to catch a flight as well. And these are some of the guidelines from the British Thoracic Society. So if you've had a pneumothorax, you cannot fly for 14 days. And that's because of the, the Boyle's law, that you get the significant expansion of gas in the dead space. And what you don't want is someone who has a small pneumothorax to develop a significant pneumothorax, while they're 30,000 feet. So we have to be very careful of that. And sometimes the pneumothoraces are small or can't be seen, or they could be delayed, happening after 24 up to 48 hours. So I don't advise anyone to fly following even a lung biopsy, even if I don't see the, this is just a follow-up CT showing a very good result and that the lesions have actually shrunk in size. Interestingly, this chap went to the US, and then he came back and he had significantly progressed with a lot of liver metastases. And look at his lungs, nasty, nasty stuff. But just out of interest, you can see that the ablation zones are actually smaller in size. So it's probably a little bit irrelevant, but a good initial response, but very poor overall response. And that's just the way it is. And again, showing that my tumor over here is nicely reduced in size. So another very interesting patient. Can you hear me at the moment, Jamshed?
Yes, we can. We can hear you very clearly.
Okay. So this gentleman had about 12 metastases in his lung, or 13 actually. And I'm a bit reluctant to take on 13 metastases, but I did in his case because he was serving as one of the ambassadors. And so he's someone who's able-bodied and working, in a very important position. And the other thing was that his metastases had been relatively slow growing, and we had lots of CT scans over a 2-year period. So I thought, fine, we'll go ahead and we'll treat him. So I start on one lung, and here you can see lesion 1 being treated. Nice. This is what you want to see. A tiny bit of a pneumothorax there, not a problem. I'm now targeting lesion 2 on the same lung. I'm also aspirating the pneumothorax as I do that. And you can see ablation 2 going ahead, aspirating the pneumothorax at the same time. And now I'm deploying a third electrode into a third lesion. So we've got lots of things happening, and it's difficult to show all the needles in place, but it's just to show that I've left the one probe in so that I can keep the lung anchored and so that the lung doesn't collapse towards the mediastinum. So I'm positioning electrode 3, even though I've finished the ablation in one of the lesions, so that I can just keep hold of the lung and keep aspirating the pneumothorax as I go ahead. And there you can see me targeting that third lesion. And 4 days later, I'm now treating his lesions in the other lung. So I'm going to do all of these in one setting. And there's that one treated there. Nice halo surrounding the lesion, which is what I want to see. Pneumothorax, not a problem. We'll just aspirate it and press on. And now I'm treating the second lesion, but I'm still controlling my pneumothorax. It's probably advisable not to let the anaesthetist know, otherwise they will panic and cancel your case. So I just say all looks good. And he went on to, we actually got control of those lung lesions, but he then had local recurrence in his primary lesion. So although the initial PET was negative, he then developed recurrence, and unfortunately he then did pass away, I think 2 years later. So RFA metastatic RCC Mets. Just a couple of, she's got 3 lesions. She's a very obese lady. I want you to look at the amount of soft tissue we've got over there. And you can see these lesions. So there are 3 lesions. So what I did is I treated the lesion on one side. This was done under GA. And then after that, I treated the lesions on the other side, just with like a gap of, I think, like 2 days later. So all 3 lesions nicely treated. And even when I'm treating the lesion, on one side, And I noticed there's a pneumothorax in the other lung. It's just something to be careful of, because you don't want both lungs going down at the same time. But that's probably because of the positive pressure from the ET tube. So I think as long as you recognize it and you've got your chest tubes ready to deploy and the patient's stable, you can just go ahead, and it probably doesn't matter even if they get bilateral pneumothorax, as long as you can manage and control them. And she did very well. No adverse sequelae. So 3 months later, she comes to me and she says she's got a productive cough with purulent material. So then I did a CT. This is the lesion there where we've got a lot of consolidation. But the two lower lesions, they've actually, I've got sort of two abscesses within the necrotic area within the ablation zone. And it's both a good and a bad sign. It's a good sign in the sense that if you've treated the whole lesion and you've got necrosis and empyema, you're probably going to get a good result. In the short term, however, you do have to manage them with antibiotics, and so it can take a bit, and you might have to put a chest drain. I didn't on this occasion. I just aspirated them, and she did, and put her on 6 weeks of antibiotics, and she did very well. She didn't attend for her next follow-up, although I did see a CT done much later on, and I can see that the lesions have significantly reduced in size after a significant time period. So like I said, you know, they can do very, very well. I'm I'm not going to go into the point that when we have the lesions, we have to feel about when we're flipping the patient and how we're going to deal with them. Because I treated this lesion provided they've not had chemoradiotherapy is good, but we're getting with serious lesions against conventional or conformal radiation therapy and SBRT, which is the sort of the state-of-the-art cyber knife. So this is sort of more conventional radiotherapy, and what you see here that this patient has a mediastinal contour, and they actually have a good response at the back, bronchiectasis with fibrotic scarring, and even anteriorly. So this is with the sort of more conventional. What can we do? Cyber knife. So just one gamma knife is for head and neck cancers only. So we've only got cyber knife. I'm taking into account the patient's respiratory movement, one center in Pakistan, in Karachi, but there are. Look at a systematic review with a meta-analysis for stereotactic body radiation therapy for colorectal mets. And if you look at their results, progression-free survival at 3 years was 13%. So when I think if you've got several lesions, even if you get state-of-the-art cyber knife, I think the ablation is still a much better option, provided they're amenable to ablation. Obviously, if they're plastered against the mediastinum, then you can't do that. And this is the 3-year survival. But if you look at the overall survival, nearer 50%, and you can see the ones with the colorectal cancer mets tend to do better than the non-colorectal mets, which are probably 40-year overall survival. And that brings me to the end of my topic. I'm not sure how much of that you were able to hear, but I hopefully some of it. So thank you.
Thank you so much, Zahid. That was an excellent talk, and they were really good, interesting cases. There was little tiny patches in the middle where we couldn't hear you, but on the whole, I think we heard all of the talks. We really enjoyed it. I mean, broadly speaking, when we're doing lung ablations, we're doing them for either metastases, most commonly things like rectal metastases, or for primary usually non-small cell lung cancers. And I think you had both of those cases, all those cases in there. Jana, what was any questions on the messages?
Yes, we have one question. Have you come across any clinically significant hemoptysis post-ablation?
I would say, apart from that one case where there was a small amount of hemoptysis in the ET tube, I'd say no. And as soon as I do get bleeding, especially with RCC mets, as soon as I get bleeding, I start the ablation straight away. I'm not going to reposition the probe. I'm not going to do anything. I just want to turn that blood and coagulate it ASAP. And I'll worry about where my needle position is later. I tend to get more hemoptysis following lung biopsies, and I've had a few patients, and I think as long as you know, as soon as they get hemoptysis, as soon as you put the affected side down and put them in the lateral position, it doesn't matter even if they bring up 200-300 cc in the space of 10-15 minutes. In my experience, it always stops. But certainly in the setting of ablation, just make sure you're not in the pulmonary artery, and just ablate and coagulate it, and then think about what you're going to do next.
Thank you. That's it for now.
That's right. Yeah, let me see if I have any specific question. Nothing in particular. I think what we need to listen to is what they say with microwave ablation now, because Zahid's given an extraordinarily good experience of RFA. And there's a few little technical things that I wonder about, because sometimes you want to skewer the lesion and move it about a bit with your probe. Now I hear that the microwave antenna are not that robust, but the advantage of microwave is that maybe there'd be, in theory, less bleeding. I don't know. So it'd be interesting to hear the next talk as well. And I think this is a really good segue to going on to the next speaker. But thank you so much, Zahid. That was amazing. Good talk.